Good afternoon and welcome to the Montana State University College of Nursing's Center for Interdisciplinary Health Workforce Studies Spring Webinar Series focusing on the behavioral health workforce. Our series is also co-hosted by the Behavioral Health Workforce Research Center at the University of Michigan School of Public Health. We're pleased to have you all joining us for today's webinar. My name is Christy Friedman and I am the program manager for the center. We also have a blog post detailing the genesis of this series if you visit our website at healthworkforcestudies.com. A couple of center announcements to mention before we begin today's webinar. We've posted on our website a new data brief on current trends of men in nursing report. This data brief updates data on the number of men working, minorities by gender, age by gender, employment settings, and new degrees awarded to men. Second, center researchers Peter Bierhaus, David Auerbach, and Douglas Steger were featured in a Health Affairs blog post last week titled, "How Should We Prepare for the Wave of Retiring Baby Boomer Nurses?" that details implications for the more than 1 million retiring baby boomer RNs and offers strategies to prepare for this challenge. There is also eye-opening data on the lost years of experience in the nursing workforce this wave of retirement will bring. We have a link to that post on our website as well. Third, we've just released first quarter 2017 RN employment trend data that details key findings, including although total employment of registered nurses working on a full-time basis leveled off in the first quarter of 2017, hospitals did add roughly 26,000 RNs. Secondly, employment of younger aged RNs fell while the number of older RNs in the workforce increased noticeably. Hourly RN wages ticked up slightly during the first 3 months of 2017 as well. Please visit our website for the complete details and figures for this quarterly data. And finally, summer is right around the corner. We're already knocking on the door as it is here in Nashville. Please save the date and make plans to attend the 2017 National Forum of State Nursing Workforce Centers Conference titled The Nursing Workforce and Health Reform, Trends and Opportunities in a New Political Era. And this conference is being co-organized by our center and will be held June 7th through 9th, 2017 at the Grand Hyatt Denver in Denver, Colorado. More details, including sponsorship and registration information, are available on the National Forum of State Nursing Workforce Centers website at nursingworkforcecenters.org. Please visit our website for all this and more, again at healthworkforcestudies.com. After today's presentation concludes, we will have 15 to 20 minutes for discussion and Q&A. Please feel free to type any questions you have in the area designated for questions on your menu bar, and we will get to as many of your questions as we can. We're also recording the webinar today and we'll have it posted to our website. We have posted all of the previous webinars to our website if you missed any of the previous ones in this series or others. You can also find presentation slides for many of the webinars posted within the video library tab on the center's website. Now, I would like to turn the microphone over to Peter Bierhaus, Center Director, and take a moment and introduce our speakers. Peter?
Hey, thanks, Christy. Welcome, everyone. I'm coming to you from Montana State University in Bozeman, Montana, and I am delighted to briefly acknowledge and introduce Angela Beck, who is the Principal Investigator and Director of the HRSA SAMHSA-funded Behavioral Health Workforce Research Center at the University of Michigan School of Public Health. Dr. Beck is also serving as a clinical assistant professor of health behavior and health education at Michigan. Angela's research is currently focused on development of a minimum data set, studies of characteristics in practice settings, and analysis of professional and legal scopes of practice for the behavioral health workforce. On a personal note, Angela, it has been a privilege for our Workforce Center to work with you and your Workforce Center to provide these 4 webinars this spring that have touched on various realms of the behavioral health workforce in the U.S. You personally and all the investigators at Michigan Behavioral Health Workforce Research Center are doing a wonderful job and truly are performing a timely and important service to the country. So with that, Angela, I'll turn the microphone over to you so that you may introduce our webinar speaker today. Angela?
Well, thank you, Peter. This really has been a wonderful collaboration between our center and your center, and very much appreciated. As you mentioned, this is the fourth and final webinar in this series, and I hope that so far, collectively, they've been successful in providing an overview of behavioral health workforce research needs, sharing examples of successful workforce development models in the field, and summarizing how policy changes will potentially impact behavioral health human resources. And today, we'll hear about challenges and opportunities facing the psychiatric mental health nursing workforce. But I think we've just scratched the surface in highlighting the important workforce issues in behavioral health through this webinar series. So if this is a topic of interest to you and you'd like to see more of these types of webinars, please let us know either through communication with Christy or you can reach out to me directly. It really helps us to be able to communicate to our funders that these are topics of importance to the field. You can find information for our center staff as well as policy briefs and reports of completed studies that we've conducted on the Behavioral Health Workforce Research Center website, and that's at www.behavioralhealthworkforce.org. So now I'd like to introduce today's presenter. Kathleen Delaney is a professor in the Department of Community, Systems, and Mental Health Nursing at Rush College of Nursing in Chicago, Illinois. As a teacher and practitioner at the College of Nursing for the past 30 years, she has blended her academic, clinical, and research roles. Her academic role includes Program Director of the Psychiatric Mental Health Nurse Practitioner Program and Project Director of the Rush Graduate Nursing Education Demonstration Project. As part of the demonstration project, she has published on nurse practitioner educational training models and on competencies for integrated care. She began workforce studies as a member of the Center for Mental Health Services Group, Alliance of Mental Health Care Professionals, who compiled national mental health workforce data. Currently, as a co-chair of the Illinois Center for Nursing, she conducts state workforce surveys of RNs and APNs, attempting to understand how to match workforce demand, capacity, and capabilities. She also conducts workforce surveys for the American Psychiatric Nurses Association and publishes on psychiatric mental health nursing workforce size, capacity, and capabilities. Kathy has really been a tremendous scholar and leader in this field, and I'm so pleased that she's able to share information with us today on a critically important segment of the behavioral health workforce. So Kathy, I'll turn it over to you.
Thank you very much, and thank you for that very nice introduction. And thank you for all the people that are taking an hour out of their busy day to attend the webinar and learn a bit more about the psychiatric mental health nursing workforce. Here's what we're going to talk about today. First, I'll give an overview of the workforce, and so you can understand its size and characteristics and distribution. I'll talk about some of the challenges I believe we face right now, including clarifying some of the misconceptions around the capacity of our workforce to alleviate mental health shortages. And also addressing an evolving narrow definition of our discipline as alternative prescribers, and I'll explain what that means. Finally, I'll talk a little bit about opportunities I see for both PMH RNs and advanced practice nurses to use their capabilities to address access to care, to build effective and efficient interprofessional teams, and to address issues around service engagement. So we'll begin with an overview of the workforce. It's important to know that a psychiatric mental health advanced practice registered nurse holds an RN degree and then a graduate nursing degree specific to psychiatric mental health nursing. They are nationally certified as either a PMH clinical nurse specialist or a PMH nurse practitioner. Both of these titles operate under the same scope of practice. There are about 15,000 of us, 4,700 clinical nurse specialists, and about 10,000 NPs. This might look a little different than the publicly reported data because I removed duplicate certifications. 63% of all CNSs work in direct care roles and prescribe. And why do I make note of that? Because in many other specialties, clinical nurse specialists might work in hospital roles or educator roles, but in psychiatry, they have always been direct care providers and continue to be. I use data on that from the American Psychiatric Nurses Association 2016 survey, and I'd like just to take a minute to say what that was. It was a survey we sent to all certified psychiatric advanced practice nurses. We received 1,694 unique individuals responding to the survey. The survey included 46 questions that were consistent with the minimum data set of the Forum of State Nursing Workforce Centers. So when I refer to these data as the APNA survey, that's the survey I'm speaking of. Who are we, demographic-wise? As you can see from the slide, we're largely female. We're largely white. We have an average age of 54. The CNS group is slightly older than the NP group. Most of our respondents were prepared at the master's level versus the doctor of nursing practice level. Within this group, it's important to note that about 25% received their degree at a postmaster's level. That means that these are psychiatric advanced practice nurses that had a previous nurse practitioner CNS degree, their family, adult, and they chose to come back and get a second degree in psychiatry, a second certification. We see that 32% of respondents completed their education more than 20 years ago. Just as Peter's newest article, we see in the advanced age category about 28.5% of respondents plan on retiring in the next 3 to 5 years. So this is important for us in thinking about our pipeline numbers and our need to replace these retiring APRNs. How are we trained? It's consistent across all programs. It's directed by national competencies. These competencies were developed by an organization called the National Organization of Nurse Practitioner Faculties. They are developed by a group of 6 or 7 leaders, experts in the field, and then widely vetted. Our 118 graduate programs follow these. These are both master's and doctor of nursing programs. They're growing, but the last time I got a custom report from the data center at AACN, there were 118, so that's the number I'll report. There's a little yellow asterisk because currently, in line with the APRN consensus model, since 2014, all APRNs now graduate from Psych NP programs. There are no longer Psych CNS programs. I'll just spend a minute saying what the APRN consensus model was. It was national guidelines that systematized the roles and educational preparation of all APRNs, 4 roles and 6 populations. This consensus model delineated that the PMH population going forward would be a lifespan degree. For a complicated set of reasons, that meant that only PMH and P programs would operate in the future. It also means, as I say in the last bullet, that PMH and Ps now are educated across the lifespan and licensed and certified and licensed to treat children. Given the PMH NP educational pipeline, I anticipate considerable growth in the specialty. Remember, we have about 15,000 right now. Currently, however, we have 6,377 students enrolled in one of the programs at either a master's or doctoral level. I'll let you read the increases in the last years in enrolled students. This is data from AACN enrollment and graduation. The reference for that is at the back. This enrollment puts the specialty on target to reach the HRSA estimate that by 2025, our workforce will be about 17,900. This was a HRSA publication called Projecting the Supply of Non-Primary Specialty and Subspecialty Clinicians. In some respects, when you look at that number, we're getting closer to the size of psychiatry. Clinically active psychiatrist numbers vary depending on the report. 23,000 in a report put out by Staff Care, 45,000 in the latest HRSA, counting all psychiatrists under the age of 75. But irregardless, we're small at 15,000 to grow to 17. Small, particularly compared to social work, psychology, counseling, but not so small when we're side by side with psychiatry. Now, the availability of PMH and Ps and APRN, the availability of PMH programs varies, and the state practice regulations vary, and it probably impacts on this APRN distribution you're seeing in front of you. The lighter shade is lower density of APRNs. So the low density states such as Nevada, Oklahoma, Illinois, South Carolina, West Virginia, a lot of these only have one NP graduate program in the state, or in the case of Illinois, when we had two for many years, both were clustered in Chicago. States such as California and Texas have more programs, but such large states, even with 4 to 5 programs, do not produce the level of PMH NPs needed to fill state need. Who are the high density states? The darker states. They're smaller states with several programs, such as Massachusetts, Connecticut, Washington State. We see that states with favorable scope of practice regulations over many years tend to have higher density, and that is in the Northeast. States that traditionally have not been favorable to APRN, such as the state I reside in, Illinois, we have the 6th lowest density of psych nurse practitioners, APRNs. Until recently, we had 2 programs. They were small and they were situated in Chicago. So as you pull apart each state's density, you can start thinking about availability of education, scope of practice regulations, and also the actual population density of the state. The details about what I just said are in an upcoming psychiatric services publication. You can see it here. And you can get any details that I might not have made clear or that you want more information on in this article. Now I'd like to talk about what I see, and this is my opinion here, on challenges facing our workforce. First of all, our diversity, we have a challenge as similar to the NP workforce, to be honest, of lack of diversity. You can see here, according to our APNA survey, we're about 75% white. We have 4.2% African Americans, and while not shown on this graph, 3.8% Hispanic or Latino descent. This is pretty much in line with the larger NP studies done by AANP on diversity. So while not ideal by any stretch, we are consistent with the NP workforce. Let's talk about communities where principal APN practice is located. Again, this is APNA data. You can see by this that about 35% of our workforce practices in larger communities between 50 and 250,000. When you get to the bottom, smaller communities, you see about 8% practicing in these smaller communities. So we mirror issues with shortages of psychiatric providers in smaller rural areas. We have a challenge disseminating information about the capabilities of the workforce. In some federal reports, such as the one shown, were not even mentioned. This is true not just of this one, but other federal reports. In summaries on the workforce, such as this one produced by American Hospital Association, we are mentioned in the beginning, and then when the solutions are posed, there's no mention of our workforce. I don't think it's because they have anything against nurses. I just don't think that there was enough information out there about our workforce. Sometimes in research articles that are important about estimating what our behavioral workforce needs are, we're either mentioned very briefly, and what's discussed about our workforce is inaccurate. In this article, it said we were a workforce that was diminishing in size and that not a lot of graduates were going into this specialty, which isn't true. So this lack of knowledge, in my mind, impedes workforce planning. Here's a current publication of HRSA on national projections. You can read the title. In this publication, we were called the wrong thing, behavioral healthcare nurse practitioners, which we're not. The facts about the workforce in some respects were wrong. It said that NPs can only prescribe in some states, which is not true. They can prescribe in all states. In a similar document on primary care, HRSA noted that FNPs, family nurse practitioners, can provide 80 to 90% of the care provided by primary care physicians, and thus should be seen as alleviating the projected primary care shortage. But when they get to this report on psychiatry and behavioral health, they do not consider PMH NPs with that capability, even though we could also deliver 80 to 90% of care provided by psychiatrists. Thus, I think we have to do a better job of educating healthcare planners about our workforce, and I appreciate the opportunity to be on this webinar and hopefully do some of that. Now, that being said, we do face the challenge of also building an understanding of state laws, which determine practice parameters and regulations. This math was taken off of NCSBN website. The link is below. You can get maps on all forms of advanced practice nursing, authority and practice regulations. Here we see that it might be a little bit confusing to navigate because in full practice states, which are in blue, 22 of them at the current time, PMH NPs can treat, prescribe medications without physician supervision, diagnose, treat, order diagnostic tests without physician oversight, but under the licensure authority of State Board of Nursing. 17 states have some restriction on practice. The remaining states, all in pink, hold restricted practice regulations, which direct a level of supervision, delegation, or team management of NP practice, again, in pink. So research demonstrates there tends to be an increased number and growth of NPs in states that allow greater scope of practice authority, and in those states, expanded healthcare utilization, particularly among rural and vulnerable populations. And that reference is in your reference list. So it'll be important as we move forward to be clear and concise with healthcare planners about the impact of state regulations and what psychiatric NPs can and cannot do in independent practice as a result of that. So as we build an accurate picture and understanding of scope of practice, we want to get across the idea that PMH and APRNs are educated and certified and licensed to provide the full range of mental health services. This is again from the 2016 APNs survey of APRNs. And what we asked respondents was to tell us the percent of if the services they provide to most patients, some, few, and none. You can see as you go down the list that the respondents said to most patients, 55% they provide diagnostic treatment, 69% diagnostic treatment of chronic illnesses, 71% drugs for acute and chronic illness. You see that they provide education to a large percentage of most patients, which is true for most advanced practice nurses. We also made our own range of services beyond, because we wanted to look beyond prescribing, and those skills can be overlooked, we think, in the rush to fill prescribing roles. So we asked our respondents to say, again, what they provide to patients. You can see that while some, say to half, they basically prescribe medication management, there's also a good deal that combine psychotherapy and prescribing. And again, we see the strong role of psychoeducation. So as we move forward, we have to understand the need for providers who can deliver the full range of mental health services, including prescribing. But it will be a challenge to hit the appropriate level of pushback on a narrow depiction of PMH APNs as alternative prescribers, which is the title we're given in some realms. Now, what do I see as the opportunity to improve access and quality via the effective use of the workforce? One opportunity is that PMH APNs practice in virtually every setting where healthcare is delivered. Here we see from our APNA data, 86% were employed in clinical practice, and approximately 60% practiced in ambulatory care, also in emergency departments. 20% of respondents indicated they practiced in community mental health centers. I think that this transportability of skills brings tremendous opportunity to improve access to care, to bring care to where prevention should occur in schools and where behavioral health care needs emerge in corrections. We have smaller numbers of PMH APNs in corrections in schools, and so that's not on this graph, but they do practice in these settings. I might note here that the majority are licensed to provide across the lifespan, but in this survey, only about 4% of respondents treated exclusively to children and about 10% to adolescents. So we see that while we are greatly expanding our workforce, we'll need to think about expanding the age range also of who our graduates treat. We have a very big opportunity for increasing effectiveness and access to care by building teams where members work to the top of their education and scope of practice. We have 3.3 million professionally active nurses. That number grows. When they do RN surveys, about 4% of nurses practice in PMH RN roles. So that's about 136,000 nurses in psychiatric roles. Primary care really is taking the lead to expanding RN roles. A significant national trend is RN primary care roles with functions such as case management, care coordination, assessment, and triage. Care coordination by PMH RNs in community-based care settings has resulted in better recognition of medical conditions, reduced cost, and improved quality of life. They're efficient case managers as demonstrated by studies done by DRUS. RNs have skills to recognize different intensities of need, which can be matched with appropriate intensity of services. So-called STEP models of care seeks to treat service users at the lowest appropriate service tier in initial instances, only stepping up to intense specialist services as clinically required. We see a greater role for the RN in all of the skills I've listed here, including STEP care intervention models. And we're looking at what training of these RNs will optimize these skills. The National Council of Medical Directors recently issued a report where they support, it's called the Psychiatric Shortage. It's on their website, National Council's website. An excellent discussion of why team-based models of care will increase access to psychiatric services. So when we look at what will be the optimal use of PMH APNs in these models, again, developing algorithms to level care. We know that measurement-based care is coming, and we need to have a team monitoring those metrics, designing population health initiatives, quality improvement around attrition from mental health services, and probably we see the future for PMH APNs as direct delivery of care to complex patients and leading collaborative care teams. Nationally, we see service centers as Intermountain Health, a large managed care network, which PMH APNs have been leaders in designing patient-centered cultures of care and effective stepped care models. And in these models, these team-based models, PMH APNs are included, and they demonstrate their organizational and systems knowledge to improve and innovate. So as we look forward, we see opportunities not just for APNs, but for optimal use of RNs in teams. Finally, we see the opportunity to improve service engagement. It's really a complex mix of perceived need for treatment and barriers which limit access that results in poor service engagement. It's been estimated that there's a 50% failure to return for treatment or adhere to treatment recommendations delivered within specialty mental health care. Treatment engagement strategies are becoming better understood, but they've been slow to emerge. We know that peers will play a critical role in service engagement, but so will the interpersonal skills needed to enact what consumers value. Clinicians who convey a sense of respect, acknowledge that what consumers say matters, and embrace a partnership model designed to reach solutions. And I've always appreciated this model of recovery-based care, so we can think about that engagement has to go beyond the basic core interpersonal skills. For nursing, our specialty, our disciplinary foundation is really in the relationship. And so what we also isolate is the importance of the individual's narrative. I'm going to let you read that quote, that first quote. So we see in this model a very crude triangle, but I wanted to capture the interpersonal process we in nursing see is needed to reach the level of narrative understanding. So the nurse begins with presence, setting the intent to listen, directing awareness to the qualities of the interaction that should be established from the onset, respect, genuineness. We see next an empathetic bridge must be established. We move into attunement, a little bit beyond empathy, to build a quality of engagement, a response to the affect state such that, as Dan Siegel says, the consumer feels felt. Attunement also builds a sense of significance of the individual's internal world, how they are experiencing their illness and expressing a concern or need. These concerns are embedded in stories which convey the meaning an event holds or an individual's interpretation of events over time. The aim then for nursing is understanding the lived experience of the individual and their choices to express particular elements of the experience. We believe that PMH, RN, and APRN skills in promoting a relationship, including another level of the interpersonal process, will create a common understanding of the individual's self-defined illness and their views of health and recovery, which will be essential to service engagement and meaningful service engagement. This is not a shameless plug of every article I've ever written, but I know this is a short, brief snapshot, and colleagues and I have, actually this has just gone online, an article that summarizes what we see as the challenges and opportunities and the capabilities of the workforce. Finally, I'd like to talk about the challenges and opportunities and what policy issues this raises for us as a specialty. One, we know little about RN and APRN roles on care teams, what they do well, what they do to improve teams. So we need support for research on RN and APRN roles in effective integrated team models of care. And I know two of my colleagues are taking up this research, and we'll be interested to see their work. We need to collect data on state-level adequacy of mental health providers, and then we can consider that PMH APRNs as providers to mitigate our current HPSAs, mental health care HPSAs. Currently in the country, we have 4,627 designated mental health care HPSAs. And I think that as we understand state-level distribution of providers, this could be something that we could systematically assess how the presence of a PMH APRN mitigates the shortage. We need to eliminate billing practices that contribute to the invisibility of PMH, RN, and APRN, particularly practice, so-called incident to billing, which we will not get a good picture of NP services when billing records do not accurately reflect who is doing what with patients. And harkening back to the state regulation map, we need to advocate for all APRNs to practice to the full extent of their license. So thank you very much. I think I'm just about on time.
Perfect. Thank you so much, Kathy. That was a wonderful presentation on the challenges and opportunities we have in front of us. So again, I'll remind the audience, at this point, we're open to questions. Please use the questions area of your GoToMeeting toolbar to enter your question and try to be as concise as you can. That helps the speaker answer. That'd be great. And we'll pose as many as we can to our presenter. I know I had one question earlier, Kathy, that you gave a figure of the percentage of the workforce that looks to be retiring in the next 5 years. Could you repeat that figure for us?
Sure, I'm sorry. I didn't have it was 28.5% per our data of our respondents, 28.5 see themselves retiring in the next 3 to 5 years.
Okay, great. Okay, the first question. So how do you believe the PMH specialty can best address the geographic maldistribution you discussed in your presentation?
Right. I think that we know that folks tend to practice where they're educated. So in my mind, we need to think about, and I'm going to talk from my own state of Illinois, we need to increase recruitment downstate. Now, I understand there's online programs, and I run one, but if someone downstate has never even met a psychiatric nurse practitioner, they're not going to be attracted, and we have a small fledgling program in the middle of our state that just isn't attracting people. So we need to think about how we can help go into some of the larger hospitals, I think, in downstate, and kind of talk about our role and talk about the potential of our role. So more people from rural areas in a state will start coming into our programs. And I think that we, in some respects, need to keep our master's level programs, which tend to be more affordable and shorter, so that, and I think might be more attractive to some of our downstate people.
Great,
Thanks.
Good point. Okay, have another question here. You mentioned measurement-based care. This is critically important. What are your suggestions on how to embed this in undergraduate nursing curricula?
Oh my goodness, that's a good question. You know, I often say I also push back a little bit from the PHQ-9 being the panacea of all measurement instruments and all measurement, but it's a good one. You know, it's a good one to start. In my own medical center here at Rush, we're starting more universal screening in all our primary care clinics, 2-item PHQ-2 and then the PHQ-9. And so I think that undergraduate nurses can learn the whole idea of how to use those scores to form registries, and then how to start looking at who's improving, who's not, and just get them in that mindset that we're going to be looking at populations in service centers on those kinds of parameters. Mm-hmm. With a caveat that there's more than the PHQ-9 in the world.
Great. Okay, have another question for you. How do you see the development of these specialties with the increase in telehealth? How do you see telehealth impacting this?
I think I read I am on so many online, sites. I mean, online share sites. But I thought I was reading yesterday that only 1% use of telehealth right now. Much conversation about it, but actual use of it, not that great at this point. So the potential is at National Council meeting, the session on the rules of telepsychiatry was standing room only. The interest in it is great. But as first we'll have to have state rules get more systematized, and then it will probably, depend, I hope it depends on consumer preference. Mm-hmm. So I guess that I'm thinking out loud. I think the jury is still out on the penetration of telepsychiatry, although the conversations around it are everywhere. Mm-hmm.
Great. I have another question about education level. What are the anticipated impacts of greater numbers of DNPs entering the practice in PMH in an augmented role? I was looking at the newest American Association of Colleges of Nursing enrollments and graduations. That's a mouthful. And I want to say of that 6,000 figure I gave of enrolled students, I want to say about 1,000 of them were in DNP programs. So although DNP programs are growing, I'm not sure we know what the impact of those graduates are anywhere for any specialty at this point. I could be wrong about that.
but the potential impact, I think, will be, I hope, a bit better grasp of the mechanics of quality improvement and measurement-based care and value-based care and population health. Just a good solid grasp, which everyone's going to have, but I hope they enter the workforce with that.
Okay, going to the opposite spectrum here. What entry-level certificate programs are used as a pathway for those even in middle or high school students to try to enter these types of advanced mental health practitioner career paths? Are you aware of any programs at those levels?
We have, again, I'm sounding a little Midwest-centric here, and I'm sorry about that. We have in the Midwest collaborations with a local community college for a career path, but it is a career path into the RN role. We also have in nursing a great, what would you call that? Not a movement, but a great interest in a career path from an ADN to BSN. It's got a name where there's a smoother transition across two colleges. And those are probably the most promising career paths, especially for the ADN to RN career path seems like an answer to increasing diversity because ADN programs tend to be a bit more diverse. So I think those are really important career paths, but to the psych nurse practitioner role, there wouldn't be a direct one, I wouldn't think.
Okay, I have a diversity question. You said 75% of NPs in the workforce are white, only a little less than 4% are Hispanic. With the increasing Hispanic population, what is being done to increase the diversity of nurse practitioners? Are you aware of any efforts for diversity in that aspect?
You know, we've been so fortunate to have the SAMHSA Minority Fellowship Program for so many years now. And recently, the SAMHSA Minority Fellowship Program was opened up to master's level and DNP level schools. And I'm hoping we really take advantage of that and make sure that every slot is filled there, because we at Rush have a SAMHSA Minority Fellow right now in our faculty, and she's a great asset to us. So I think one of the ways to increase diversity is to increase the faculty and to work with, in Illinois, we have the Hispanic Nurses Association, and we, at the Illinois Center for Nursing, we're talking with them and we brainstorm, but again, the best solution out there looks like the ADN pathway. I don't know of another one, systematic one right now. But again, please email me if you have one that I've forgotten, that I don't know of, I mean.
Great. I have a question about the education programs. Are you, as a whole, are you seeing a shortage of faculty to teach in these programs? Is that impacting supply for the PMH workforce at all?
Well, I mean, if you read anything put out, again, by AACN, they'll let you know that the faculty shortage in all specialties in PEDS, that qualified applicants are turned away because of that. So you could extend that to psychiatry. But it is, from the people I communicate with, because there's only 118 of us and a lot of us know each other, it's very difficult to get faculty for programs right now. And I'm not sure, it might impede, I don't know if it's impede, I hear a lot of new programs opening. I'm not sure it's impeding new programs opening, but we keep to certain ratios of students to clinical faculty. So when you can't get faculty, it will impede them growing. Mm-hmm.
Yeah, I just wonder about maybe some of these folks retiring, if they might consider becoming a resource in that matter.
Oh, dear. Yeah.
Okay, I have one more question here. Would the certified behavioral health technician, an entry-level position, help fill a small gap for the MH care providers' needs? Is there such a market for this role?
Well, you know, I think that's been such an interesting role. Here in Illinois, it's called the community health worker role. And again, Illinois has been a bit stalled because of budgetary reasons, but there was a pretty, I would say, a lot of enthusiasm for developing the community health worker role. And within it, teaching them about stress reduction. And but then when in Illinois and Chicagoland, when it came to actually employing this new workforce, it didn't go as smoothly. So, you know, when you read about the development in each state, there's a different title. Would it help? Absolutely. Would development on payment for peer counselors and peer specialists help? Absolutely. Do we know how? I think there is one paper on peer specialists, but we don't really know what the community mental health worker in mental health would do for, say, like something like attrition and service engagement. Would they improve it? I would think, since I remember at Academy Health, I went to a presentation about the increase in service engagement when your provider speaks the same language. So it just is intuitive that as we increase anybody in a service center and their fluency in the language of the population they serve, as well as their knowledge of the cultures of those populations, we're going to improve service engagement. So yeah. Mm-hmm. Sorry, that was a circular answer. I was thinking on my feet. I hadn't thought about it.
That's okay. You mentioned that the graduate degree PMH NP is across the lifespan. Are graduates beginning to see children?
Well, at this point, again, the APNA survey, the American Psychiatric Nursing Association survey that was conducted, we're not seeing a great deal yet, seeing exclusively children. We used to have a certification for just children, CNS certification. We don't have that any longer. So at the current time, our respondents, only 4% said that they see exclusively children. I want to say about 12% that said they see some children. So hopefully, if we keep our questions consistent, we'll be able to track over time if we see an increase in our graduates seeing and addressing the treatment needs of families and children. We certainly hope so. Being a child mental health nurse myself, we certainly hope so.
Okay, and then I have a question for you, and you can approach it however you'd like.
Okay.
There's a lot of push now about integrated care and team-based models of care from the perspective of this of the PMH workforce, nursing workforce. What do you see are the biggest kind of challenges and maybe opportunities for really helping that catch on and facilitating team-based care?
That's such a good question. Here at Rush, we have a Doctor of Nursing Practice program, and probably about 6 of my students, my advisees, are doing projects in integrated care, trying to help the service site with people taking on new roles and understanding what is my role in medical. For psychiatric nurses, what's my role in medical management of patients, and for medical nurses, what's my role in the behavioral management of patients? So I see tremendous growth. We all know that many consumers would rather be treated in integrated care. They prefer it, its ability to increase access. But we haven't done a survey on how many schools of nursing are actually, what % of their practicums are in integrated care. So I see that we have a tremendous opportunity. The recent HRSA grant that's out right now, the Behavioral Workforce Training HRSA grant that is currently at play, wants applicants who train in integrated care. So I think that if we can start, our graduates usually are in clinical practice training for about 1 year across a spectrum of service sites. I hope more and more we start providing training in integrated care, because I think nursing is a good fit for that. But what I hear from people is that it's not, on paper that model looks very clean, but in the reality of it, it's a little messier. So I'm hoping that we in education can do something in our training to give people a boost up into those type of service sectors.
Right, because if you're only doing it for those just coming out of school, they may face an uphill battle in an already established practice or system, trying to kind of come in and change things around. So maybe some certificates or other types of educational needs, maybe in that type of training that might help some of those who are already out in the workforce kind of buy in, maybe.
And it's interesting, and I know that Peter might be on this line, but in our specialty listing on our APN surveys of our minimum data set, integrated care isn't one of the options you can check as what you work in at this point. Peter can correct me if I'm wrong. So I think we need to add that so that we can track people working in integrated care. We can't add every subspecialty, but it would be great if we could add that.
That's a great idea. I have one housekeeping question for you. Will you make your slides available after the presentation?
I think they'll be available on your website.
Great, thank you so much. Well, we've got just a couple of minutes here to finish up, and I'd like to thank our speaker today, Kathleen Delaney. Thank you so much for taking time to deliver a wonderful presentation. And this will conclude our Spring Behavioral Health Workforce webinar series. All the previous webinars may be found under the video library tab of our website. We also post slides there and other resources that you can find. So just take a look there if you're hoping to share this with some colleagues who maybe couldn't attend or want to go back and check some notes. I'd also like to say many thanks to Angela Beck and the Behavioral Health Workforce Research Center at the University of Michigan School of Public Health for helping to organize and host this series. And we will see everyone again this fall. We take a break over the summer with our webinar series, but we'll be back this fall with another round of webinars under a theme, so stay tuned. Thank you so much.
Thank you so much. Thank you for having me.